In 1929, when the college was founded, maternal mortality in the UK was very high, around about 4.6 per thousand births. In developing countries, the maternal mortality figures are very similar to what we saw in the UK in the early 20th century. And the causes of death are exactly the same. And we know that the improvement in maternal mortality in the UK was due to improvement in social living conditions, access to blood transfusion, antibiotics, and to training in obstetrics, particularly in emergency obstetrics.
Trying to dress up into theatre linen so that we can proceed with the cesarean section that we are going to have right about now. We usually give prime gravidas 12 hours to deliver, and she started yesterday at 9. It's past 12 hours, and right now the fetal heart is slowing down. On my examination, she has signs of obstructed labor, so I'm rushing her to theatre. We were able to operate on Violet in time and to save the life of her baby and her life because our theatre was in place. It's well equipped. We also got some volunteers from the UK who helped us in providing continuing medical education.
At first, you could be quaking, you could have a tremor because you think the baby, how will the baby get up? The volunteers taught us that when you get an asphyxiated baby, just be confident.
If this theatre wasn't here, she would have gone to Mulago Hospital, but Mulago is overwhelmed with patients. So she would spend probably the next 8 hours without being operated on. The only way we can stop the overwhelming numbers in our national referral hospitals, that is Mulago Hospital and other regional referral hospitals, is by making sure that we put up a good referral system, and on top of that, making sure that in those lower level health centers we develop staff. There's staff development going on and more funding so that patients can quickly access good medical services or surgical services. If Violet had not had an emergency cesarean section in Kasangati Health Center, she could have had serious problems. That is to her and her baby. Probably the baby would have had, there would have been an intrauterine fetal death, and to her she could have, got an obstetric fistula.
So the WHO say that there's about 2 million women and girls living with fistula today, and probably between 100,000 and 150,000 new cases per year. If you have a fistula, life can be absolutely appalling because you're leaking urine or feces all the time, you smell, people avoid you, they ostracize you, you're stigmatized.
But I pushed for long, about 9 hours. Push, the nurse was telling me, push, and I pushed for very long. So after that, the urine started dropping. The doctor checked me and told me, you have a problem with fistula. He told me that go to Chitovu, they will help you. From the hospital, telling me that I have to go to Chitovu and operating me, I waited for about 2 months. If I couldn't get this operation, I could lose my job, my husband.
And the work that's going on in places like this is fantastic because they're treating huge numbers of women and really totally changing their lives. But what would be even more fantastic is if this service was a permanent one, so we had trained enough people to be able to keep this service running 12 months of a year instead of the wards lying empty in between different camps.
It could be better when we had our Uganda doctors to operate us with that fistula, because we could find no problem they could operate us very early, not to wait for so long with that problem, waiting for the doctors from outside the country.
Already fellows and members of the RCOG are having a big impact. They're involved in training, they're involved in fistula surgery, but there's so much more we can do because the need is huge.